This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
And welcome to the human side of healthcare. We're delighted you're with us today. You know, Thomas, sometimes children have heart problems.
You know, we've talked about this openly on the show. I've got one, but I waited until I was about 55 for mine. I think we're going to hear that it can happen a lot earlier than that.
We absolutely are. We're going to talk to Dr. David Sutcliffe. He's a pediatric cardiologist at Children's Health and UT Southwestern Medical Center, and he is going to talk to us about some of the problems some children have.
You know, when we think about heart disease, I think the elderly gentleman or lady really is what comes to our mind. Now, having said that, heart disease in children is not all too uncommon. There are usually about three buckets or three different diagnoses that we think about that children are affected in heart disease. One of those is congenital heart disease, a birth defect of the heart that is from the formation of the child. The second is cardiomyopathies, and those are heart diseases where the muscle of the heart is actually put together in a way that causes problems. And then the third is acquired heart diseases, and those are heart diseases that something along the way of life has led the heart to not work quite as well as it should. The ones that we think about most commonly are congenital heart diseases, and those happen in about 1% of births and live births on a yearly basis, and that comes out to about 40,000 children per year are affected with congenital heart disease. It's the most common birth defect. As for the total volume of patients with congenital heart disease, it now comes to around 1.1 million children in the U.S. and 1.4 million adults, and that volume of adults really speaks towards the success that we as a field have had in taking care of kids through their childhood and getting them into successful and healthy adults. Although the health doesn't always last, and sometimes children can develop heart failure early on in life, whether that's from a congenital heart defect that can't be repaired or wasn't repaired effectively, or a heart muscle problem like a cardiomyopathy, like I spoke about just a moment ago. Cardiomyopathies, those occur in about 1 in 100,000 children, and that's equates to about 5,000 new diagnoses every year. And then acquired heart disease, things like immune-related diseases, maybe chemotherapy-related diseases where the treatment for a cancer adversely affects the heart, or things along the lines of cardiac damage related to infections or things along those lines. Those tend to be the major problems of heart diseases in children, and we have all sorts of different ways to take care of them and try and care for those children and keep them well as best as possible.
So in looking at some of the situations you deal with, I'm assuming, congenital heart defects or other heart problems could cause heart failure in children.
That's absolutely right, Steve. So the most common heart failure that you think about in the U.S. today, the true public health problem, the epidemic that we're dealing with is heart failure in adults, equating to around 6.5 million patients affected on an annual basis across the world, U.S. However, though the number is smaller in pediatrics at around 7 per 100,000 patients, that equates to around 14,000 admissions a year of children with heart disease. And so that doesn't just affect a child, that affects the whole family. The whole family is taken out of work and taken out of their daily lives and really forced to face what can be a very horrible and unrelenting disease. We have lots of medications to be able to manage these types of diseases, but it's a very difficult diagnosis for a family to hear, that their child's heart is failing, something so core to who they are and who the child is. Families have a very difficult time with this diagnosis.
You're so right. It's got to be just devastating to parents, especially when their child has heart failure. And you mentioned pharmaceutical, but what are some of the other innovative ways and techniques that you're now treating heart failure in children?
Well, from the pharmaceutical standpoint, like you mentioned, we do have some of the time-tested therapies that are used in adults. And we have a couple medications that are on the horizon and really exciting. We at Children's Health and UT Southwestern are involved in the first trial in a new medication that's been available to treat heart failure in decades, a medication called Entresto. We're really excited about what that potentially has to offer to children. But medications don't always provide the support that kids need. And as heart failure can progress, sometimes they need things like surgical intervention to be able to help them. And that may take the form of heart transplantation, a time-tested therapy to help kids with end-stage heart failure. But that's a very tenuous group that we deal with. Those who need heart transplantation are typically very sick children, and they're at risk for getting worse and even not surviving to getting to the heart transplant. And so we, as well as a number of other centers across the country, have really started to innovate using machines that are placed surgically in the heart called ventricular assist devices. And this is kind of an area that I absolutely have loved to be involved with, because it really can change the picture of what heart failure looks like for a child. These devices are made and developed for a grown man such as myself or yourself, Steve. And so we have to find ways to make them fit and work for children who are obviously a wide range of sizes, from a little baby all the way up to an adult-sized male or female.
You know, you mentioned that program that you've got at Children's Health, and I think you actually referred to it as the VAD program. How has that evolved over the years?
That's a great question. So we started placing ventricular assist devices, or VADs, in children back in 2006. And this was kind of, in no pun intended, the infancy of that kind of field or that kind of technology for children. And as time has gone by, it has grown from a program where we had one device available to us that was adapted to fit a child's form, to now, as time has gone by, 6 devices of variable capabilities and used for variable patient characteristics to try and help support them and keep them safe. And as you would imagine, dealing with 7 different devices, each with their own unique ins and outs and intricacies of that kind of therapy, we need lots of really good and very well-trained people to take care of these children and the pumps that they're being used to help support them. And really, it's astonishing to see what this support can do for kids. We take kids who are not growing and they're frail and they're having a very difficult time and suffering through end-stage heart failure, which can be very difficult to watch. And we take these children to surgery, and after recovery, we can make it through to thriving children who have strength and energy and able to keep them safely supported to the point of heart transplantation or life with a ventricular assist device.
We're listening to Dr. David Sutcliffe. He is a pediatric cardiologist at Children's Health and at UT Southwestern Medical Center. You're hearing some of the most cutting-edge technology for taking care of kids with heart defects. What a tough diagnosis, but look at the potential outcomes that can be had. And this is right here in the Metroplex. That's the cool part. And we have this on our podcast, which is also cool, The Human Side of Healthcare. More with Dr. David Sutcliffe from Children's Health and UT Southwestern Medical Center next on The Human Side of Healthcare. Stay with us.
This is The Human Side of Healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back. Could you imagine being a parent and having to sit across from a doctor and hear that your child has a major heart problem? But could you also imagine hearing that problem could be solved, especially through technology that was not even available years ago? If you didn't hear our last segment, it is worth a listen. It's on our podcast, The Human Side of Healthcare. That's where you hear about the technology. Now we're going to hear about some of the metrics, the quantification. In other words, the lives changed. We're talking with Dr. David Sutcliffe. He's a pediatric cardiologist with Children's Health and UT Southwestern Medical Center. Steve?
You know, for our listeners, I know they're fascinated by this good work, but you mentioned it started in 2006. So we've had approximately 14 years. As far as metrics or outcomes, can you share any of the results with us?
Sure. So we are one of the busier programs across the country now. We are, from a volume standpoint, on par with maybe 4 or 5 major institutions in the country. Over the span of these 14 years, we actually just hit a really important benchmark. We just implanted our 100th device in a patient, which is really quite exciting. There's only a handful of centers across the country that have made that achievement. And it has really changed the ability for us to care for these kids and keep them well supported. We have survival rates of a highly complex and technical surgery and support course that could potentially be met with adverse events or problems, but a survival rate of upwards of 85 to 90% of children.
85 to 90%. That's tremendous.
Yeah, that has changed the landscape of caring for children with heart failure over the past 2 decades, just night and day. It has really given kids who otherwise wouldn't have a chance at survival a healthy and strong life to live.
I wanted to ask you a question, and I don't want mothers to feel guilty. That's not the purpose of the question. But prenatal care. Prenatal care is very important, obviously. As a pediatric cardiologist, listeners that are expectant mothers or mothers in the future, are there some do's and don'ts related to prenatal care that might help prevent some heart problems?
That's a great question, Steve. So the formation of the heart when a child is still developing within her mother is a complex interplay between the environment that the child is exposed to, the genetics they have underlying, and the environment that mother has provided for that child. And so things along the lines of taking your multivitamins and pregnancy vitamins, having regular follow-up with your obstetrician, and making sure that you are living a healthy life can only provide the best environment for development of that infant heart that is developing. Beyond that, having close follow-up with your obstetrician can really uncover diseases that mothers really can't have any control over. There are elements in how a child develops that are really related to the genetic code and what the building blocks that make them who they are. And some children will be destined to develop congenital heart disease. Now, having close follow-up with your obstetrician can uncover some of those heart diseases and allow preemptive planning before the child is born to be able to provide them the absolute best care available to them. And so close follow-up with your physician and having the best environment available for that developing child is what I would say is the most important.
What about premature delivery?
Sure. So the organogenesis, or the development of organs when an infant is developing or an embryo is developing, usually is focused and almost complete by the time that children get to a viable age for birth. So the early environment when babies are developing, or developing babies are forming their heart, is of a critical time within the first trimester. By the time children are reaching the 3rd trimester, which even in extremes of prematurity is typically when children have reached to that point, most of the heart formation has occurred. Now, children, when they're born premature, are obviously facing a very stressful environment. They no longer have the comfort of their mother's womb. And so at that point, we have to support children and provide them the best nutrition, the best overall support to be able to care for them. Congenital heart defects or even cardiomyopathies are not necessarily at a higher risk in prematurity as much as managing the transition from the mother's womb into the world.
You mentioned that ventricular device. How do you get it from adult size down to kid size? Take us behind the technology here.
That's a great question. So it takes an innovative team to be able to come up with ways to make the technology fit. And that starts with a surgeon and cardiologists who think outside the box per se. And so we have moved towards performing CAT scans or CT scans for patients before we do devices, so that this technology can be uploaded into almost a virtual reality space, so that we can actually perform testing to see if the device will fit into the child's heart, into their chest, to see if it's a viable surgery or whether we have to change our technique or change our approach. So it's not just the medicine, but the technology, and where the two intersect is really where the innovation happens.
You mentioned when you were talking to Steve, I can't imagine a family getting this diagnosis, and often I would imagine you are the one who gets to bring them into the room and sit them down. What do you and what does Children's do from there on the coping with this side?
Yeah, you're absolutely right. For most families, when they have this diagnosis offered to them, this is a low point in life for them. From that point into the past or into the future. And so this is a time where the emotional and physical support is absolutely critical. And it takes a very broad team of people to care for a family and a child to successfully move through this stage in life. We have social workers, child life specialists, we have psychologists, we have a whole battery of folks that are really at the ready to be able to support families as their children are fighting the fight against heart failure, which is really quite challenging. It's a privilege, however, to be able to not only see these families and these children at their low point, but to be able to provide them the support to get their child healthy again and walk through that journey with them. It is just a fantastic living.
I could only imagine. Talk about serving. We live in a world of 6 degrees of separation, and in this case, probably more like 2 or 3. And no doubt in an international town like this, people know people around the country and even around the world who might be facing this in their own families. How do people get to you?
So I think the most important thing is to trust your gut. If a mom feels like her child is just not doing well, trust your gut. If you feel like your child needs to be seen, trust your gut. If you show up to an emergency room and you get an answer that's not satisfactory, it doesn't sit well with you, keep pressing. Because eventually someone will listen and someone will understand what you're going through and get you to the care that you need. So Children's Health is a great center for the city of Dallas to be able to provide care to children who are in need. It's what we would call in the medical field a tertiary facility. We have the most elite and the most advanced opportunities for medical care possible. So in the way that we have children referred to our center is that we have great relationships with cardiologists, not only in our community, but in community all around the state of Texas and all around surrounding states. And so find your physician who's going to listen to you and get you to the care that you need, because the connections between the medical field and the medical community towards children's is really fantastic.
Thomas, what an amazing discussion with Dr. Sutcliffe. It is tremendous what we're doing in pediatrics, especially dealing with hearts.
That's a tough interview to listen to in ways, because we could all imagine sitting in that chair across from him in some kind of way. And Steve, people in North Texas do. And that's got to be one of the most painful conversations you could possibly have. But the technology is absolutely phenomenal.
Yeah, the things that pediatric cardiologists can do now, and even the future technology in comparison to 10, 15, 20 years ago, is just unbelievable.
And this is such an important topic that you may know someone who is in this position, or it may be in your own family. We have a podcast, The Human Side of Healthcare, and this whole interview can be found there. And then they're talking about transplanting hearts. And, when a baby is born and that's the ultimate solution is to transplant the heart, that technology that Dr. Sutcliffe was telling us about is the bridge between the diagnosis and the transplant. So I think a natural parlay to this would be, let's talk about transplants.
I totally agree with you. I think we need to talk about transplants, and especially in pediatrics, And so why don't we bring a segment in to do that?
We're going to be talking to Dr. Dev Desai. He's the Chief of Pediatric Transplantation at Children's Health and the Professor of Surgery at UT Southwestern. So we're going to move from diagnosis now to solution when we come back on the human side of healthcare.
Welcome back to the human side of healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
And welcome back to the human side of healthcare. You know, we just finished a great discussion with Dr. Sutcliffe related to pediatric cardiology, but sometimes the answer is a transplant. And we're delighted that we're going to be talking to Dr. Dev Desai, who's the Chief of Pediatric Transplantation at Children's Health and also a professor at UT Southwestern. Dr. Desai, welcome to the show.
Thank you for having me on.
And Dr. Desai, when would a child need a heart transplant?
Sure. For children, many times organs such as the heart, liver, or kidneys don't develop normally. There are what we call congenital diseases, so that is the child is born with a disease and it affects the organ where it is not able to function properly and provide, the necessary needs of the child. For example, there are children who are born where the heart, normally has 4 chambers. There are conditions where one of the main pumping chambers is absent. So that creates a situation that's not compatible long-term with normal life. And similarly, there are conditions for the kidney and the liver, as well as intestines.
So generally speaking, in broad categories, what organs would you say can usually be donated?
So we have 2 forms of organ donation. There is living donation and deceased donor organ donation. Obviously, living donation is limited to organs where you can either remove part of the organ safely without compromising the health of the donor, or that there are 2 matched organs where one can be removed, such as a kidney, which is the most commonly donated living donor organ. With deceased donors, a deceased donor, actually many organs and even tissues can be used to help patients in need. And so with deceased donors, there is the heart, obviously 2 lungs, which can be individually transplanted, so you can help 2 people. Same with the 2 kidneys; they go to 2 different individuals. A liver and the intestines; those are what we call the solid organs that are transplanted, along with the pancreas. The pancreas can be transplanted for those with type 1 diabetes. And then there's tissues such as corneas or ligaments, and we also now have what we call vascularized composite transplant. So that is a hand or a face transplant.
When you think in terms of living organ donation, I knew a man, he and his wife had an infant, I think was about 9 to 10 months old, and really had a need for a liver. And actually, there was a match found, and a portion of a relative's liver was actually used to save the infant's life. Is that where you mean part of an organ?
Yes, exactly. The liver has the capacity to regenerate and grow, and the liver can be divided in very specific locations such that a part of the liver can be transplanted from an adult to an infant, or even from an adult to another adult. And then the liver would grow in both the donor and in the recipient to the size that is needed by that particular patient.
That's remarkable, the kind of work that we're doing in transplants. Along those same lines, I'm going to pivot just a little bit. Can you tell our listeners why you encourage them to be organ donors?
The thing is that there are certain diseases that can only be treated with organ transplantation. And there are some organs, such as the heart, where only a heart from a deceased donor can be utilized for transplantation. There's no living donation options for patients with heart failure. And I think, when someone has passed away, that person, sort of their final sort of act, can, save the lives of potentially eight different individuals. There are a number of myths surrounding organ donation that I think have hindered people from donating organs. One of the common myths is that one cannot have an open casket funeral, and that's not true. The organs are removed in a way that can still be feasible. Every major religion in the world has endorsed organ donation. And then I would say the last thing is that, I think there's a myth that if you're an organ donor and you get sick and are in the hospital, that the hospital won't do everything they can to save you because there's such a need for organ donation. And that's completely false. The hospitals will do everything they can to save someone's life, regardless of whether you're a donor or not. So I think, I would encourage people to really look into organ donation, speak to their spiritual advisors, speak to their family members about potentially, signing up to be an organ donor, and certainly speak to healthcare professionals, your primary care physician, or attend many of these Donate Life type events that are held throughout the community to bring organ donation awareness and the need for organ donors. In the United States, roughly 22 people die every day while waiting for a life-saving organ.
You and I were chatting a little bit before this broadcast, and I think it's important for our listeners to know, you're talking in terms of where someone makes an informed adult decision, maybe to even indicate on their driver's license that they're an organ donor. But when you have a tragic accident involving pediatrics, where you can secure some organs that can save lives, the fact that you're transplanting these organs to save the life of a pediatric patient is remarkable. But unfortunately, at the same time, someone in another family just lost a child. That's got to be difficult.
That is, it's extremely difficult, not just for those of us that work in pediatric transplantation, but it's also difficult, for the parents of the child that needs a transplant. They are keenly aware that, their child needs an organ to live, but that unfortunately another child may have died to help save their child. And what I can say is that, having spoken to many donor parents and families over the years, they really find comfort in knowing that their child was able to help another child or multiple children live. And that allows these families to have some closure, to make some sense of what I think is probably, one of the worst things as a parent that I can think of, and that is to outlive my children. I feel like as a parent, I should not live longer than my child. And I can't imagine anything worse for any parent to have to go through. But these are really the true heroes, these families who, in their time of greatest need, can look beyond their sorrow and loss and find a positive and can unselfishly do something to help another fellow human. That is one of the things in what I love about what I do, is I get to see, that side of people helping others, at probably one of the worst times in their lives. And it really is very renewing every day to see that, especially when we hear about all of the tragedy and things going on, especially in the last year with all the lives lost, from a virus.
Absolutely. And that kind of brings me to my next question. You covered the myths about organ donation. This past year, we've been dealing with COVID-19. Has that in any way impacted your work?
I mean, initially it did have an impact, especially around this time last year when we were still learning a lot about the virus. We didn't know, exactly how it was transmitted and how deadly it was or wasn't. And so some transplant activities were put on hold for a brief period of time. We stopped doing living donor transplants, because we didn't want to potentially expose a healthy donor who was going to donate a kidney to potentially getting the virus or being in an environment in the hospital where there were patients with COVID. And also deceased donor activities did go down because it wasn't safe to travel. The hospitals were at capacity, the ICUs, and there was a shortage of PPE. So especially like in hard-hit states such as New York City and New York State, early on in the pandemic where they were really, the health system was overrun, transplant activity went down. But by the summer, things started picking back up. And this past 2020, believe it or not, we did more in the United States. We did more organ transplants than we had done in 2019. So the donors, the health transplant staff and doctors really rallied to try to save as many lives as we could.
This has been Dr. Dev Desai, who is the Chief of Pediatric Transplantation at Children's Health and also a professor of surgery at UT Southwestern Medical Center. Dr. Desai, thank you so much for being with us. We're going to keep this conversation going with Dr. Alejandro Mejia. He's with Methodist Health System, chief of the transplant program there, who is going to talk about organ donation. That's coming up next. Stay with us on the human side of healthcare.
Covering the healthcare topics that matter most to North Texas. This is the human side of healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
And welcome back to the human side of healthcare. You know what, Thomas? Transplants save lives.
There's nothing more important than kids. We've talked about that for the last half of the show here. And now we're going to talk about just transplants in general, because amidst the tragedy of one death, one of the things you can do, as you well know, is you can give life to somebody else. Have you checked your driver's license to see if you have that heart on it? Steve, I know you have one. I do too.
Absolutely. And to learn more about this, let's switch from Children's Health and now let's move to the Methodist Health System.
We're going to be talking to Dr. Alejandro Mejia. He's a transplant surgeon there and is the executive program director of organ transplantations there at Methodist.
Dr. Mejia, welcome to the show.
Steve, thank you for your kind introduction, and I'm delighted to be here.
And for our listeners who may not be that familiar with transplants, can you give an example what a living donor is?
Okay, well, first of all, living donors are very, very special people. These are patients who decide that they want to donate one of their organs. Currently, a living donor can donate one kidney. You can donate half of your liver. Currently in Dallas, we have programs who do living liver donors and living kidney donors. So we're one of those programs. Basically, somebody comes up to donate one of their kidneys to either a loved one or a friend. It doesn't have to be a blood relative. So we usually have a very diligent process in testing the potential donor to make sure, first of all, that they're healthy and that their health is not going to suffer by donating one organ. And then, we go through all the other issues, like make sure they're financially clear, make sure that their job is not going to suffer after they donate, make sure they really want to do it, make sure there's no pressure from any side of either the family or the relationship or any other type of influence. As long as we know they're doing it, for a good reason, and of course, make sure that they're medically clear. Then the last thing that goes into this is to make sure they're compatible from the immunology standpoint, because sometimes a person can reject X number of organs out there, but then somebody may be a good match, meaning that the person who's going to get the organ is not going to experience a rejection. So all those things are factors into somebody deciding to donate an organ to another person.
Kind of pivoting a little bit, for the people that consciously decide they want to donate organs and maybe even designate it on their driver's license, we certainly applaud those people. But for people maybe that tragically have their life taken via an accident, such as a car accident, when their family decides to give those organs, is that done at the hospital, or can organs be transported across the country?
Okay, so that's a good question. So the tragedies, I guess, that are part of transplantation are really followed by their loved ones making a decision that they want to donate. You can register as potential donors in case we are declared brain dead, but the ultimate decision, will be by our loved ones. So once this happens, depending on what hospital this takes place, sometimes either in smaller hospitals, they can be transferred to larger hospitals, or currently we have a donation center in Dallas where basically the potential donors are transferred there for procurement of these organs. And that's actually where the placement of these organs happen. It's a nationwide system where your loved one organs can go to anywhere in the country, to any patient in the country, because they're a better match or so forth. Same thing, with the livers go to potential recipients in a radius of like 250 to 500 miles. So yes, to make the answer short, yes, the organs can be transported, and that happens every day. They just have to be specially, flushed and preserved so that the organs are not injured or harmed in this process.
When you think in terms of a donation, especially if unfortunately it's one where the donor is deceased and the family of that donor, obviously is going through a very difficult time. And yet the person that's going to receive the organ donation, their family has hope, and they're filled with excitement that hopefully this is going to preserve the life of that recipient. So, from an ethical point of view, how is it handled when a recipient's family would like to meet with the donor's family to express their gratitude? That's got to be some very sensitive and difficult discussions.
Yes, thank you for that question. It's a very special moment every time we see a donor family reunite with the recipient of one of their loved one's organs. It's a process because we don't know exactly how the emotions are, especially immediately after the donation happens, which, as we mentioned, this is usually following either a tragedy or medical complications. So we first need to make sure that both parties are wanting to meet. And this is something that happens over several months. And usually what we do at our center is we have our, recipient usually writes a letter. And our social workers are really great about this. They write a letter to the donor family, and we kind of make this letter go to the donor's family through the organ procurement organization. Then they contact, the donor family, and at some point they will receive the letter, and then it's up to that family if they want to reply. And once there's some communication established, then in the future, and again, I'm talking about months, they can sometimes decide that they want to meet. Sometimes there are families that don't want to meet the recipients, or there are some recipients who really, they're dealing through so many medical and personal issues around the transplant that sometimes they don't want to think about it immediately. Most of the recipients eventually will be ready to kind of meet the recipient. It's a very special situation when we see that, and as you mentioned, there's no better legacy than to see your loved one's organs, save somebody else's life. And I want to mention we also do the honor walks in our hospital. When somebody donates in our hospital, and I think this happens in other hospitals as well, we honor that donor, that branded donor, as they're rolling the hospital into the operating room to undergo the surgery in which all their organs are removed for donation.
Thomas, what a tremendous show. We've talked about pediatrics. We've talked about saving lives. I'm going to do a quick pivot. I'm worried about kids that are drowning. Have you seen the number of kids that have drowned thus far this year in North Texas?
I think, 2 just in the past week or 2?
Absolutely. Parents, please be careful with your children around pools, around lakes, around any bodies of water.
Great reminder, Steve. Thank you for that. And we will wrap it up for this week. Thanks for being with us. Stay safe out there.
We'll see you next week on the Human Side of Healthcare.